Welcome to Module 1 of the course ICM Strengthens Midwives and Midwifery Globally. On each slide there is an audio recording for you to listen to alongside the presented material. Each slide corresponds to documents found in the tile Documents on the home page. These documents are available for you to deepen your learning and understanding and may be a resource for your everyday work. We do hope you enjoy this module. The learning outcomes for this module are as follows. You will understand the ICM, their vision and mission, as well as understand the structure and governance of the ICM. We will explore the scope of ICM's work at regional, international and individual levels. In addition, you will learn the key domains of ICM's work such as strategy, policy and practice, education, regulation, supporting midwifery associations, advocacy and research. And overall, you will gain a clear understanding that ICM is the global voice for midwives. The ICM is an accredited non-governmental organisation which has 500,000 midwives, 132 member associations in 113 countries across 6 regions of the world. The ICM has a clear vision and mission. We envision a world where every childbearing woman has access to a midwife's care for herself and her newborn. Our mission is to strengthen Midwives Association and to advance the profession of midwifery globally, by promoting autonomous midwives as the most appropriate caregivers for childbearing women, and in keeping births normal in order to enhance the reproductive health of women, their newborns and their families. To reach the goals of the ICM is committed to working locally with the Midwives Associations, regionally across the 6 regions, globally on behalf of the 500,000 midwives represented by the midwifery associations. The ICM values include working collaboratively, working with equity, responsibility, accountability and integrity. This diagram provides a brief overview of the extensive work of the ICM. Strategy, policy and practice, supporting member associations, education, regulation, advocacy and research. We will discuss these in more detail shortly.
The ICM is an organisation that's set up to support midwives associations around the world. There are around about 130 midwives associations who are members currently in 113 countries of the world. So effectively the ICM is the voice for over 500,000 midwives all around the world. And we have a role as the global voice for those midwives, really trying to promote the role of the midwife and why a midwife is so important for every country in terms of providing really good quality maternal and newborn health care. And more importantly, one of the fantastic things that happens is every 3 years we have a congress and midwives come from everywhere. There's a lot of sharing that goes on, lots of learning, lots of support. And I think every midwife, everywhere in the world, there is a heart that we all have, which is about being with women in birth, strengthening those women, building their confidence, helping them to become confident and strong mothers so that their families are strong and their communities are strong.
The challenges that midwives face are very similar, irrespective of economic status of their country. The issue of recognition is universal. The midwives is still not as well recognized as one would like to think, whether they are in high-income countries or low-income countries. There is a shortage of midwives globally. There's no one country today who could say they've got adequate numbers of midwives.
So what the ICM is trying to do is to actually make people aware of the really important role that midwives play and why they need to be established in systems that do support them and allow them to work to make the difference that we know they can make.
Midwives save lives, especially when they are well educated and their practice is regulated and they are supported and organized in a strong association.
The overarching governance body of the ICM is the Council, and that is made up of each member association having 2 delegates. The Council votes on the board. So the board is made up of an executive, which is a president, a vice president and a treasurer. Then the ICM is made up of 4 regions at the moment, and those regions have meetings during the council meeting where they have a number of nominations for people who will come from the regions to join the board. And so what you end up with is a board, and they have the mandate from the council to have a closer connection with the day-to-day business of running ICM. And they have a governance role. They're not there to represent their region. They're there as the voice for midwives globally.
Associations belong to ICM, and all of us are speaking with one voice on behalf of women and newborns. They have the possibility of having their voices heard. In high-income countries, there is an issue of over-medicalization of birth. In low-income countries, it's the actual reverse. The problems are more related to the lack of resources. It's quite easy to see a midwife doing her best to deliver, to assisted delivery at night using a mobile phone light.
Many midwives associations are very interested in supporting others, and that's not one way. It does not mean that midwives in high-income countries know everything and are going to somehow tell midwives elsewhere. That is absolutely not the case. There's definitely mutual learning to be had, and that can be enabled through ICM. We can share resources, build resources that actually work for everybody.
I enjoy working with the ICM because of the passion and dedication of the people and the leaders here. But another reason that it's great to work with the ICM is because they have a clear view of what is happening on the ground with the individual midwife who is taking care of that baby and that mom in her clinic, wherever that may be in the world. They also have a macro view. What is the right thing that we need to do for all midwives around the world? So it's really great to work with them because they are really looking at the whole span of midwifery, and as a profession and as individual midwives.
Because ICM also believes that midwives are the key, we know that it's really important that midwives are educated, that they're skilled, that they're regulated, that they are respected and supported and able to practice as midwives to make the difference for women and their families.
This video captures the role of the ICM and the importance of its vision and mission. Situating the global context and highlighting the importance of qualified, competent and regulated midwives, this video also provides insights to the ICM structure, its governance, council and board. The ICM is governed by an international council, the decision-making body of the organisation, which develops ICM's 3-year strategy at each triennial council meeting. The council appoints board members according to processes set out in the ICM constitution. The elected president, vice president and a treasurer from the executive committee of the board works closely with the chief executive to achieve the ICM's 3-year strategy. The council is made up of 2 members from each member association and the board. The board includes the executive committee, president, vice president and treasurer. The chief executive attends board meetings in an ex-officio capacity with no voting rights. Board members are appointed for a 3-year term, which can be renewed only once, and there are 5 standing committees that advise the board: education, regulation, research, finance and risk, and the scientific professional programme. All these details and more can be found on the ICM website linked on this slide.
Okay. Alright, Fran, so just look at me, pretend the camera isn't even there. First, let's pretend we're meeting for the first time. What's your name and what do you do? What's your title?
I'm Fran McConville, and I work on midwifery at the World Health Organization.
Great. So this report that came out today, I know it was a long time coming. Can you talk about how it got started and just briefly, the history of making this report happen?
Okay, it was a long time, and there's good reasons for that. But it started really because when I arrived at WHO, there was a lot of very good work going on disrespect and abuse of women in childbirth, and that is very worrying. But when we dug a little deeper, we started to think, so why? Why is this happening? And a lot of the blame was being presented as if it was coming from all the healthcare providers, but particularly around the midwives who have the closest relationships with the women. And we know, and myself as a midwife, that if that's happening, then there's something wrong with the system. Something isn't working right, because you don't become a midwife for fun. You believe deeply in the rights of women and the quality of care. So we started to think we need to hear from midwives themselves. And frankly, we discovered that no one had ever listened. And having worked for over 30 years in Africa, Asia, and in the Middle East countries, we know their conditions, and I've been with them. They're awful, the conditions where they have to work. So at the Women Deliver conference in Kuala Lumpur, I put up a sign that said, "Do you feel safe, respected and empowered?" thinking a handful of people would turn up. We presented research from Papua New Guinea, from Afghanistan, Nepal, and about disrespect and abuse as well, and burnout and how people feel. And the room was packed. We couldn't fit enough people in. People were sitting, standing, squeezing in, and over 100 people were queuing up outside. So we all of a sudden realised, at last, here's an opportunity. People need to speak and hear what's going on. So we took that work back to WHO, and we did what's called a systematic mapping of the literature. And we thought we'd focus on the three things that had come out from this first discussion. Was we often focus on the professional barriers. Do you have enough supplies and equipment? And what we found out, that's certainly one of the barriers. But secondly, is as women face enormous amount of gender inequity as childbearing women, but also as midwives. So there are some real social and cultural barriers that midwives are facing that they've never been able to articulate before. And on top of that, some of them just haven't been paid for years or months. And when they are paid, they can't even feed their children. So about a third of them were having to take these extra jobs. So we thought something really is going on here. And we put that all into this systematic mapping of the literature. And it came out with the same. These are very, very serious barriers that are preventing the quality of care, respectful care that women, newborns and their families should be having. And around that time we had the State of the World's Midwifery report that said out of 73 countries, only 4 had enough of the midwives who had the skills. And then we wonderfully had the Lancet series on midwifery, which looked actually at what do women and newborns need, and what do the midwifery personnel need to have to provide that care. So then we took the advantage of the ICM Triennial Conference in Prague, and we had a social anthropologist, and in English, Spanish and Arabic. We had about 40-something midwives from a lot of countries, and we did some good participatory mapping. And we took those questions, all combined together with a systematic review, and we thought, we've got to ask midwives around the world. So we developed these 10 questions, put them with the help of the ICM on their website, and asked them, and their societies helped us to outreach. We thought we'd get a couple of hundred answers, and we got 2,470 from 93 countries in all these different languages. And it wasn't only those who could access the internet. In Yemen, for example, they photocopied it, they went with people, they sent taxis out, they filled it out by hand, and somebody collated it all. So the desire to be heard is absolutely huge. So that's where we got to, and we're really pleased that it took that time, but it's been worth it to really listen to midwives' voices.
Okay, I have one bar left on my battery, so it just went out. I want to make sure I get the policy stuff with you.
Yes.
I think we'll have time, but to come back to some other questions. But tell me, why is it important? Why is it so hard to get midwives at the policy table, and why is it so important that they are there?
I think those two totally interlinked, and it's to do with gender, status, and the image of midwifery. And women who work with women are often untouchable in parts of Asia, and it's just seen as women's work. It's like cleaning up in the kitchen. You've done it for centuries, you've never been paid. So we don't really need to hear what you have to say. And at the same time, birth has become highly, highly medicalised. So we've had this, which makes it even more important for midwives' voices to be at the table. So it's been normal for midwives just to be told what to do, and policymakers to just make those high-level decisions, and we will tell the midwives this is what they need to do. But when they're not at the table, we've seen this tremendous rise in caesarean sections in countries such as Brazil, women's rights being lost, episiotomy, which really should never be done unless there's an emergency, being done routinely. And these are the kind of things that are going on where we don't have midwives at the table really being very clear that women are healthy and strong, and they come into labour and it's their birth, and we're there to make sure that they're fine, that there's no complications, and to support them to deliver their baby. And that's a different approach to creating policies to medicalise or make sure everybody has an injection of oxytocin, extremely important interventions, but there's a very different approach. So we need both. You know, we need the medical side, we need the midwifery caring side in the policies, so that the midwifery care is the whole spectrum right the way through. We also have examples, for example, to prevent a postpartum hemorrhage, you need to give an injection of oxytocin. Now, if at the policy table there aren't midwives, there are many countries around the world where midwives aren't allowed to give the injection. So we can't change that policy unless they know that, and we actually say things like that. So we really need to not be the only ones at the policy table, but to join the conversation to make sure it's really balanced. And most importantly, the midwife talks about the woman and the baby and the family right the way through. It's not one point in time at the birth or at the clinic. And that's what we need to get into the policy, that the woman and the newborn are really at the centre of this. She needs those interventions, but that's how we need to focus.
I'd love to have you connect this with the quality of care guidelines that are being rolled out by WHO, and sort of that bigger picture of ensuring that women are treated with respect, dignity, that whole quality, equity, dignity piece that we know needs to happen. How can just talk about that and the role of midwives?
Well, what's been really important in WHO's new quality of care guidelines around the childbirth is, for the first time, not only have we looked at the provision of care, what you do to women, what interventions they need, but their experience of care. So we've looked at their emotional needs, the importance of communication, and respect and dignity as a quality of care standard. So we've now got a much better balance. And what's been wonderful with the State of the World's Midwifery report, this report, the Lancet series, is we've taken the evidence-based language, for example, around the biological, cultural, social needs of women and newborns, and we've put that into those standards. And the framework around it also includes ensuring the rights and dignity of women in childbirth, but also, for the first time ever, I'm really pleased to say, the rights and dignity of the women who are caring for those women. And that brings together, for the first time in WHO and really across the other organisations, the fact that they're both women. Most midwives are women. There's some great male midwives as well, but most midwives are women, and they're often pregnant and are delivering at the same time as the women that they're caring for. You know, we're all together, and that they face the same barriers. We know that women have faced barriers of transport and all sorts. Midwives face the same barriers, and it's about bringing that together. So I'm really pleased that the WHO guidelines have taken this really holistic approach, the provision of care plus the experience of the woman, but also the experience of the midwife, making sure that she's okay to provide the quality of care that the women and newborns need.
Okay, now I'm going to go back to the report and talk about some of the major findings of this report and what they mean, what they tell us.
Okay, I mean, the findings really show, to start with, that this was the first time midwives have had a voice, given the numbers that came through. They also throw up the barriers. It really consolidated that they are facing professional plus sociocultural plus economic barriers. We didn't fudge that, you know, that really came out very strongly from their voices. But they also showed us they have the solutions. And the solution that came out so strongly is, if you listen to us, if you involve us, we can solve a lot of these quality of care problems. We're there every day on the ground with women. We can overcome them. But often you develop solutions without us, then they don't work. And we're the ones who are carrying them out. So we want to work with you. So the main finding really is to let midwives speak, to be heard. When policy decisions are being made, make sure midwifery leaders are there. That the solutions include not just looking at professional barriers, not just giving a delivery kit, but making sure that midwife has a delivery kit, she's paid well, and she's socioculturally supported and accepted in her community. So the findings show that getting us to that table, listening to our voices, really will make a big difference for the quality of care for women, newborns and their families.
And it will also improve outcomes, right? The health outcomes.
Once the quality of care moves, we know that. Once it starts to improve, women survive, thrive, their communities transform, as do their children, as do their families. And midwives have always very much been part of women's lives, part of their communities. So it uplifts, it's empowering women in childbirth, but also women as midwives. So whole communities are uplifted and transformed when we work together like this.
Perfect. Thank you.
The ICM is the global voice for midwives and recognises the complex issues that midwives face across the world. In some areas, access to resources or facilities or other medical professionals is problematic. Midwives also face issues with unsafe working environments and poor or no pay. Conversely, in other countries with resources, midwives face issues of restricted autonomy, unable to practice their full scope of midwifery, or face pressures of rising intervention rates which are harming women and families. And globally, there is a significant shortage of midwives. In 2014, the ICM worked with the WHO and UNFPA to ask midwives about their working lives. The findings generated stark insights to the challenges midwives face globally and reported upon in the State of the World's Midwifery Report. Preliminary reports from the next State of the World's Midwifery Report are due to be released in the summer of 2020 and the final report in 2021. Explaining the work and the findings is this video of Fran McConville from the WHO. Take the time to watch this video and consider the reflection at the bottom of the page. The ICM continues to grow and evolve. New developments will be launched on their website by spring 2020. These include information about ICM regional conferences, advocacy workshops and respectful care workshops. We have come to the end of this module, where we have covered extensive material regarding the ICM, their work, purpose and structure. We have talked through the global, regional and individual scope of the ICM's work. And we have also learnt about the key domains of ICM's work, including the strategy, policy and practice, education, regulation, supporting midwifery associations, advocacy and research. We have situated the importance of the ICM being the global voice of midwives, who face great challenges across the globe. Improving the working lives of the midwives greatly improves the quality of care that women and babies receive. Therefore, the work of the ICM is essential to making these improvements. In the next module, we will explore at greater depth the work of the ICM regarding standards, positions and tools. These are resources designed to improve the standard and quality of midwifery care. We do hope you've enjoyed this module.